then the posteromedial approach, then the posterolateral approach. Now we have which approach and strategic planning. May I invite Dr. Rajiv Rai Chaudhary? So you are going to simplify for us.
Sorry?
You are going to simplify for us.
I'm going to...
Simplify the whole thing.
Yeah, I think probably it's going to be a very... can we start, please? Okay. So, whenever you are in a military situation where the word strategy comes from, and the topic is strategy, in such a situation you should have a goal, the aim that should be very clear, which is for us all intra-articular fractures. And the first rule is know thy enemy, and that is analyze your CT scan well, which I will tell. Know thy terrain, so whether it is osteoporotic, what is the skin condition, etc. Know thy resources. Based on this, you would plan your approach and plan your tactic. So if we see this, 40 years of Schatzker and 7 years of Luo's 3 concept, Schatzker is virtually thrown out. Although a pioneer, but last year now we have from a 3-column concept, we heard of a 5-column concept, we have a 10-column concept, so the only thing that is constant is change. I'm not going to talk about the soft tissue lesions that affect, but always remember, even the minor single column fracture can be associated with a soft tissue complication, so don't take the severity of the fracture as an indicator. Even a less severe fracture can cause problems. The fracture is not going to change. The soft tissue will. And so, consider this fracture as a soft tissue injury with just a broken bone inside. Now, how do I analyze my CT scan? So, I'll first look at the fibula. Things that are anterior to the fibula, things that are posterior to the fibula. How do I further analyze? I see where the lateral metaphyseal fracture is, the medial metaphyseal fracture is, what is the depression, and what is the widening. Remember, this is a hint. Any articular depression of more than 6 millimeters may be indicative of a lateral meniscus that is lying inside the fracture site. We are talking about strategy, and we are coming to the approach. Look at your sagittal approach, study your CT scan carefully. Where is the anterior margin, where is the posterior margin, and of the fracture at the metaphyseal level, where exactly is the depression. And if you will see the last thing down there, you see on the fibular side, there is posterolateral depression. Then you look at your posterior coronal cuts and look for the depression of the tibial condyle medially and posteriorly. Know your resources. I'm not going to talk about this. Now you draw your lines on the axial view. And this is at the level of the fibula. So you have got a medial, a lateral, a posteromedial, and a posterolateral fragment. 1 column fracture equals 1 plate. Now, one of the most common misunderstandings that occurs is when you say there is a medial column fracture. Traditionally, we are used to understanding medial is full medial, while here the medial actually is anteromedial. There is a separate posteromedial column as well. A lateral column fracture, a anterolateral approach. A anteromedial column fracture, a anteromedial or a medial approach. A posterolateral fracture, and if you see here, this is a posterolateral element affected, and we have seen the Force approach, and you can have a posterolateral approach, and for a posteromedial approach, you take, for the posteromedial fragment, you take a posteromedial approach. Now this was simple up till now. We have seen the posterior approaches. You go the posteromedial and the posterolateral. We have already talked about it. I'm going to skip over this slide for a minute, and now we come to combined columns, so not single column. So if you have a anterolateral with a posterolateral, so basically a lateral, I think the ideal approach is a force approach. If you have a posterior-medial with a posterior-lateral, then isolated posterior-medial, as Sushrit has shown, with two plates going, one posterior-medial, one posterolateral, but the approach is posterior-medial. The trick for this, all should remember, just nick the fibers of the aponeurosis of the gastrocnemius at the origin point. That will relax your gastrocnemius and will allow you to see more on the lateral side. Remember, the anterolateral and the anteromedial approaches are no good for the posterior approaches. It is necessary to reduce and fix to specific approaches if you are looking at the posterior side. Fixation from the anterior approach, here we can see, will miss the posterior fragments completely. Now for a case study, 49-year-old person, that is the X-ray and a CT scan, that's the axial cut, and I have drawn the lines. Having drawn the lines, I decide the medial column is broken, the posteromedial column is also broken, the posterolateral column is broken and depressed, and there is a virtually intact lateral column. I look at the sagittal cuts, and there is a posteromedial column fracture, there is a posterolateral depression, and also a split. I look at the coronal cuts, and here I see that there is a medial column fracture and a posterolateral fracture on the other cut. So my analysis of the CT scan is posteromedial column, I am going to do a medial plate. For the posteromedial column, I'll do a posteromedial plate. For the posterolateral split depression fracture, I'll do a posterolateral plate plus a bone graft, and the lateral column is intact, so it will not require any plate. So the incisions I will plan would be posteromedial approach for the posteromedial plate and the posterolateral plate, and bone graft for the posterolateral fragment, and an anteromedial incision with a medial plate, and you can see I achieve my strategic goal. Good alignment with joint surface well restored. And here we can see these different plates that have been put from the three different approaches, and thank you very much for your attention.